dystonia. Now, the other group of symptoms we see, of course, are the cognitive problems that are part of the disease and the psychiatric symptoms. And that's much more difficult to localize because we're talking about huge networks with many, many millions of neurons involved in these processes. It's more difficult to localize to one part of the brain. But these are much more often the presenting symptoms in, is this? Okay. Well, we can try that some other time, but we'll see if it works now. But these are what causes symptoms. I wanted to talk about a couple of terms here. People can actually meet the criteria. Psychiatric diseases in general don't have specific blood tests or other tests you do. They're based on collections of symptoms. And so there are diagnostic criteria that are developed. There's a manual called DSM-4, some of you may have heard. It's about to be replaced by the 5th edition of the Diagnostic and Statistical Manual. There are many patients with Niemann-Pick C who are adult who may in fact present and meet diagnostic criteria for bipolar disorder, schizophrenic illness, major depression, and that may be the presenting symptom. And my experience is when I'm seeing patients like this, they all have abnormal neurologic exams, but the findings are often missed because people attribute the dystonia, for example, to the effects of the drugs that are used to treat these disorders. But it's very important. This comes back to the point that was made earlier. We need to be very alert to these diagnoses, particularly in younger adults, or people who are presenting in an unusual fashion with these disorders. And similarly, the cognitive problems may be very subtle early on. Often children have attention problems. Sometimes they're diagnosed with learning disabilities. But it's only over time that it becomes apparent that there's more global problem with memory, with planning, with language, and so on. So all of these cognitive functions are affected. Okay. Yes?
Does hearing have any effect?
Yes, hearing is affected. We actually published some data on this in 1989 when we knew that the brainstem auditory vocal potentials were abnormal. Then he's been studying this as part of the observational study. And certainly in clinical practice, I can tell you it's not uncommon for teenagers. We don't recognize it as often in children, but certainly teenagers and adults, it's not uncommon for us to see hearing loss. And so I'm glad you brought it up. It's a very important point because they can benefit tremendously from having hearing aids. Because a lot of the time, people's problems get, again, this comes back to a really central issue of managing this disease, and that is everything gets attributed to the underlying disease. People say it's, quote, untreatable, which I absolutely disagree with, okay? Because there are so many things we can treat, and so it's very important to recognize hearing loss. Because I had a number of patients, now teenagers, it's hard to persuade them to do anything. You all know that. And putting hearing aids in, even they can barely see the things, and they walk around all day with iPod buds in, right? So I don't know what people are doing is any different, but it can be difficult to persuade. But if people use it, it can make a huge difference. So I think that's a very important symptom. I'm glad you brought that up. And it hasn't been well appreciated until recently. Which brings up another important therapeutic point. And that is that I think we should have a fairly low threshold for treating psychiatric symptoms in patients with NPC. We should treat depression actively. We should make sure we treat anxiety because it can make a big difference in quality of life. Yeah, it's a symptom of the underlying disease, but we can treat that and often treat it very effectively. And I think that's an area that's been relatively neglected. I've been trying to get some psychiatrists in this division getting involved with these patients. So, okay. So that's neurology. You can all come to the board exams now and I'll check you out and see how you do. You may do better than any of our candidates, actually. So I think I will start talking for a minute. Now, any more questions about those? Yes?
When you were talking about the walking thing
Yes.
with the dystonia, Minnie has a tendency to every so often lean, like she can only lean to a certain side. What's that posture?
That's not uncommon with cerebellar disease. Again, it's a misinterpretation of joint position sense. You can also get it if you have trouble with inner ear function, but it's more likely to be cerebellar in NPC. Did you want to show the...
What's the name of your file?
What's that?
Which file? Is he presenting next to his Joe?
What's that?
Is Joe next to...
Maybe we'll ask Julian to speak next and talk about management of respiratory pulmonary symptoms.
So, unlike my learned colleagues, I did prepare a few slides in a window of opportunity, but I'll try not to put them to. But I was asked to. Yeah. Yes. I was asked to maybe give some of my thoughts on the respiratory management of Niemann-Pick C. And I think we're talking before, and we recognise that this is an overlap respiratory care with regard to nutritional care and feeding abilities, etc. And recognising, as Mark has said, knowing the neurological process that is occurring, really its effect on swallowing and the impact of that, and the effect on feeding that Dr. Clark may describe a little bit, the potential risk there to a child's respiratory system, all of these separate things interplay in that, and really the risk of aspirating, not only on your feed, but also on your own secretions are a significant piece there. And so first of all, in the clinic, it would always be asking clinical symptoms with regard to the respiratory system, and asking the family of the patient numbers of antibiotics, numbers of chest infections, etc., and just getting a sense of what is going on there. And then really thinking about allied support from that end, first of all. And this is where the overlap and the support of the multidisciplinary team and other therapists comes involved from that end. Really working with regard to feeding and the impact of aspirating, regular assessments and support from an occupational therapist, maybe a speech and language therapist, someone to assess a child's swallowing capability. We can utilise video fluoroscopy for swallow studies, which gets a sense of how the actual swallow mechanism is occurring there, and is there secretions or fluid being pulled here in the throat, and is some of that leaking into the windpipe and onto the lungs. So getting a sense of that. Direct management that Joe might mention is the role of anti-reflux therapy from that, to try and avoid that, to dampen down this movement of feed, certainly from the stomach up the esophagus, that could put a risk through to aspirating from that end. I won't say any more about nutritional intervention, but there's a potential strategies that we employ, both changing in the type of feed and then ultimately considering whether an artificial feeding technique would be appropriate. We now know that with support of other clinics and people, there are feeding clinics and indeed drooling clinics, and in regard to management of secretions. I think a word of importance with regard to secretions, there are medications that dry up the secretions, but they dry up everything else. They can make you more constipated and be problematic from that end. But these are support that we can link in there. And then directly with regard to pneumonia management, much of that is traditional paediatric care with regard to that. Finally, some interventions at home, the use of home suction, home oxygen, nebulizers. I'm uncertain whether the need for things like bronchodilators, ventolin, salbutamol can have a direct effect. Some families may feel that does benefit. Certainly my experience of just the process of a nebulizer and some humidification can help break up secretions and improve the situation from that end. So those are really some of my thoughts on the respiratory care for the patient. I'm open to any questions or whether Joe wants to go.
Do you want to talk about chest physical therapy?
So yes, I did actually. I've had chest physiotherapy on that regard.